It's a great pleasure to be here to share insights on two highly relevant tropical diseases with an audience that holds significant potential to contribute meaningfully to their control and to the protection of vulnerable population. I would like to express my sincere gratitude to Siemens, which has become an important partner in this mission. Early this year, we initiated a collaboration study in Brazil, making the beginning of a promising partnership in order to bring about the huge impact laboratory diagnostics have in the lives of people living under challenging situations. I'd like to begin by presenting a concrete example of how tropical disease behave in the context of climate change, environmental shifts in human dynamics. Let me introduce the state of Rondônia, located in Brazilian Amazon area. This small yellow area on the map represents Rondônia. Though small is relative, as its territory is roughly equivalent to the entire area of the United Kingdom. Today, it is home to approximately 1.8 million people. In the entire green region shown here, transportation is primarily conducted through rivers networks. Paved roads are virtually non-existent. In purple, we see the Amazon River. In red, the Madeira River, that means Wood River, that connects Porto Velho city, the capital of Rondônia state, to Manaus, the capital of the Amazon. A 4-day trip. The map on the top left corner was the natural vegetation cover as it existed up to 1985, and the one on the bottom right corner is the current situation in 2020. Between 1970 and 1986, a major highway was built, linked Rondônia to the rest of Brazil. The combination of a national policy of free landing distribution, the discovery of gold along the Madeira River, and the construction of two large hydroelectric dams on the same river, the result experienced rapid demographic growth. The population increased from 100,000 to 1.8 million in just 30 years. The arrival of a large number of people into a forest region where malaria was already endemic brought significant change. First, we observed the formation of a transitional zone, the interface between forest and the emerging towns and farms. These scenarios gives rise to what we call frontier malaria, which is marked by high mortality rates. The reason is clear. The health infrastructure, including systems of diagnostic and treatment, was not yet placed when these frontier communities were first established. In 2012, by the time the hydroelectric power plants were built, a comprehensive malaria control program was already in place. No plan existed for emerging arboviral disease such as dengue, Zika, chikungunya, Oropush, and Malaria virus. So you observe the intermittent surge breaking at that point in the area. Yellow fever was not a major issue in Rondônia thanks to widespread vaccination in this endemic area. However, during the construction period, several malaria and yellow fever outbreaks occurred in other parts of Brazil, particularly in regions where construction workers and their families frequently traveled, creating a new transition route. Nature decided to show that it's not just human playing there. In October 2024, the Madeira River reached a historic low of just 19 centimeters, the lowest level ever recorded. This was a direct consequence of a extreme drought, which in turn intensified wildfires and deforestation. As a result, dense smoke covered the sky for nearly 3 months. Less than 6 months later, in March 2025, the same river rose dramatically to 16 meters, surpassing the flood alert level and causing widespread flooding in the low-lying river communities. So, what has happened to the number of malaria and dengue cases? Case number initially declined. Rapid in-stream shifts between drought and flooding disrupted mosquito breeding sites, reducing the population of the vectors responsible for malaria and dengue transmission. However, in April, I had to explain this phenomenon on national television, emphasizing that the situation was likely temporary. I also stressed the importance of maintaining our health system prepared for potential resurgence, ensuring early diagnosis and timely treatment would remain available. What I have just presented is a recurrence pattern, one that many of you are already familiar with in different parts of the world, and it is likely to continue. That's why we must prepare and strengthen our capacity to anticipate, respond, and to mitigate its impacts. Diagnostic innovation has a potential opportunity to do good here. Okay, before going forward and discussing diagnostic tools and opportunities, a more truth review of the challenges associated with dengue and malaria is required. Let's begin with dengue fever, which, as many of you have likely observed, trends to increase in the context of the rapid and unplanned urbanization. In the next slide, I can show you dengue is a viral disease transmitted by Aedes aegypti, a highly domesticated mosquito species that has adapted exceptionally well to urban environment, breeding in a small collection of water. In addition to the classic mosquito human transmission cycle, Aedes aegypti is also capable of vertical transmission, passing the virus to its offspring. This makes the elimination of breeding sites a critical component of any effective dengue control strategy. In the next slide, I can show you that about 50% of the world's population is at risk, with estimate 390 million infections occurring each year. In the next slide, you see that, however, most dengue cases are underreported, as many are asymptomatic, mild, and self-managed or misdiagnosed. The main signs of symptoms include fever, myalgia, arthralgia, headache and fatigue, and cutaneous rash. In some cases, petechia, mucosal bleeding, and abdominal pain may also occur. In several cases, the disease can progress to a hypovolemic shock due to plasma leakage into body cavities and intestinal spaces, leading to edema and cardiovascular collapse. The life-saving intervention is aggressive fluid resuscitation. And the next slide, you can see the etiologic agent is a RNA virus with 4 distinct serotypes. Recovering from infection provides a lifelong immunity against the specific serotype acquired. However, cross-immunity to the other serotypes is only partial and short-lived. As a result, Subsequent infection with different serotypes significantly increase the risk of developing severe dengue. In the next slide, I can show you that in clinical practice, the diagnostic of dengue involves hematological, immunological, and molecular alterations. Fever typically lasts for the duration of the viremia, around 3 to 4 days. During this period, diagnosis is possible through antigen detection, such as the NS1 test and molecular methods like RDT PCR. The critical days are usually between day 3 and day 5. While most patients begin to recover, some may worsen significantly around day 5 due to hypovolemic shock resulting from the dehydration, plasma leakage, and bleeding. At this stage, thrombocytopenia and hemoconcentration become key laboratory findings. Although bleeding manifestations may occur, the primary and most dangerous event is plasma leakage, leading to the shock. Serological testing becomes useful only after the course of illness. EGM is typically detectable from day 7 to 8, and EGG becomes more prominent from the day 10 to 12. Since there are 4 dengue virus serotypes, an individual can be infected up to 4 times over their lifetime. Serological diagnostics become more complex in this context, as it often requires paired EGG testing to detect a significant rise in antibody titers over time. Moreover, due to antibody-dependent enhancement, a mechanism that facilitates viral entry in the replication in monocytes, sequencing infection are more likely to be symptomatic and carry a higher risk of severe disease. Platelets play important roles in dengue pathogenesis through diverse mechanisms. Thrombocytopenia in dengue may result from reduced plaquetal production, can occur due to the direct infection of megakaryocytes, or infection of the stroma cells leading to a suppression of megakaryopoiesis, or yet from peripheral platelets consumption. May be associated with platelet apoptosis, formation of heterogeneous aggregations between platelets and leukocytes, aggregation with endothelial cells, or yet opsonization of platelets by antiplatelet antibodies and activation of the complement system. Platelets' role in the increasing vascular permeability is related to the action of inflammatory mediators, exacerbate immune response, leading to the plasma leakage into the interstitial space. What changes in blood count in dengue? Hemoconcentration, increase in the hematocrit, is an important diagnostic criteria, revealing the high risk of hypovolemic shock and the capillary leakage syndrome. Another thing, thrombocytopenia, marked decrease in platelet count, usually below 100,000, increase the risk of bleeding, indicating clinical severity. Now, shifting to malaria. The 2022 floods in Pakistan serve as a striking example of how extreme weather events can dramatically impact malaria transmission and burden. After the flood waters recede, numbers in stagnant water pools remain, creating ideal breeding sites for mosquitoes. As a result, the country experienced an 8-fold increase in malaria cases, rising from approximately 500,000 in 2021 to 4.3 million in 2023. Events like these are expected to become more frequent and more severe as consequence of climate change. Malaria remains a serious global health challenge, particularly in the hard-hit Africa region. I estimate of 263 million new malaria cases in 83 countries worldwide in 2023. In 2015, there was a wave of optimism driven by increased funding for malaria elimination initiative in several regions. While some initial program was made, partially in reducing mortality, this momentum was significantly disrupted by the COVID-19 pandemic, which had devastating consequences for malaria control programs worldwide. However, it's also important to acknowledge that the progress that has been made since the year of 2000, global malaria control efforts have prevented estimated 2.2 billion cases and 12.7 million deaths worldwide. Worldwide. Unfortunately, as the chart illustrates, we are significantly off track compared to the targets originally projected. The green lines represent the optimism projections made in 2015, while the blue line reflects our current trajectory. In the yellow line, show the revised projection based on recent trends. Malaria typically presents with fever, chills, sweating, and headache, a pattern known as the malaria paroxysm. While textbooks often describe this presentation as intermittent fever or symptoms, that pattern usually becomes apparently only after about a week of infection, once the parasite's erythrocytic cycle is fully synchronized. In the early days of illness, symptoms tend to be irregular. Additionally, the widespread use of antipyretics can mask this cycle pattern, making it seems like the fever simply returns once the effect of the medication wears off. There are also asymptomatic infections, which play a key role in sustained local transmission. These individuals do not seek diagnosis or treatment and often carry low levels of parasitemia that can result in false negative results across nearly all available diagnostic methods. Severe cases are not uncommon and can lead to death, particularly infection caused by Plasmodium falciparum. Even Plasmodium vivax, malaria, which is typically considered less severe and can become complicated and potentially life-threatening in the presence of a comorbidity or other risk factors. 5 species of Plasmodium are known to cause malaria in the humans: Plasmodium vivax, falciparum, Plasmodium malariae, Plasmodium ovale, and Plasmodium knowledge. The first two are the most common and more troublemakers. The Anopheles mosquito is the vector responsible for malaria transmission, with over 60 species implicated worldwide. These species are highly adapted to the local environment and climates. Transmission begins when the infected female mosquito bites a human, injecting Plasmodium sporozoite into the skin. The parasite then migrates to the liver, where they undergo an incubation phase. After this stage, they enter the bloodstream, initiating the erythrocytic cycle by infecting red blood cells. As the parasites mature and erupt the red cells, they release new merozoites into the bloodstream, an event that coincides with the onset of clinical symptoms. Some of these parasites differentiate in sexual forms called gametocytes, which are taken up by another mosquito during a subsequent blood meal, thus continue the transmission cycle. My, Microscopy remains the gold standard for malaria diagnostic, as it allows direct visualization of the parasite within red blood cells. However, in many settings, increasingly so, diagnosis is being performed using rapid diagnostic tests called RDTs, which have improved in accuracy and help reduce overall costs. Molecular methods, while commonly used in research and in the bank screening, are now also being explored for point-of-care application, with effort underway to develop field-adapted molecular diagnostic suitable for use in remote and resource-limited areas. Which changes in the complex blood count are available for malaria diagnostic? In acute malaria, anemia develops rapidly. Many patients have already lost 1 gram per deciliter or more of hemoglobin by the time they seek care. The left graph illustrates the behavior of hematocrit levels in the patient with acute Plasmodium falciparum malaria. Right from the onset, we observe a marked decline in hematocrit even before treatment begins, due to directly to the parasite destruction action on the red blood cells. This is malaria-induced anemia. Once treatment is initiated, hematocrit levels begin to recover gradually. However, this recovery is low, and normally hematological values are typically restored only after a month. The graph also shows that hematocrit continues to decline for a few days, even after treatment begins, indicating that red cell destruction persists during the early phase of the recovery. This highlights the importance of continuing clinical monitoring even after symptoms begin to resolve, as anemia may continue to progress in the initial days of treatment. Because this is a hematologic hemolytic anemia, standard hematocrit indices often remain within normal range. However, hepatohemoglobin and hemoxpexin level decrease while indirect bilirubin increase, while blood cells counts typically remains at the lower limit of normal, and thrombocytopenia is almost always present. Mild elevation in transaminases may occur. AST levels or other enzyme levels rise due to both hemolysis and hepatic injury, while ALT reflects liver-specific damage. The graph on the right shows the evolution of hemoglobin levels and parasitemia in untreated patients with Plasmodium vivax infection observed in Australian military volunteers in early decades. During the first few weeks, there is a rapid rise in the parasitemia accompanied by a progressive decline in hemoglobin, reaching its lowest point around week 5. Even though malaria remains detectable, hemoglobin levels begin to recover gradually in the following weeks. This recovery occurs because Plasmodium vivax has remarked preference for reticulocytes, young red blood cells, which represent only a small fraction of circulate erythrocytes. As a result, the parasite's ability to propagate is naturally eliminated by the scarcity of its target cells. This other graph illustrates how the severity of malaria varies according to the transmission intensity and the patient age. In all endemic area, where transmission is very high, severe cases are concentrated in the young children, primarily due to severe malaria. While cerebral malaria can also occur, it's less frequent in this age group. In mesoendemic and hyperendemic regions, severe malaria remains most common in childhood, but there is a notable increase in cerebral malaria among children aged 3 to 5 years old. In contrast, in low transmission areas such as hypoendemic or unstable regions, the paradigm changed completely. Severe malaria affects individuals of all ages, including adults and elderly, with a greater frequency of renal failure and malaria and the cerebral involvement in older age group. In summary, the lower the cumulative exposure over a lifetime, the greater the risk of severe disease at any age. It's also important to highlight the variation in anemia severity across these settings, as indicated by the red line in the graph. So, the cause of malaria, anemia in malaria are multifactorial. We have destruction of the infection red cells occur when the Plasmodium parasite invades red blood cells, multiplies and ruptures them, releasing new parasites. Destruction of unaffected red blood cells, immunological and mechanical process promote the early removal of healthy red blood cells, especially from the spleen. Intravascular and extravascular hemolysis can occur by direct rupture of red blood cells in the bloodstream or removal by phagocytosis in the spleen and liver. Bone marrow dysfunctions. The infection and inflammatory response can reduce the production of new red blood cells, that cause ineffective erythrocytopoiesis, leading to anemia. Hemoglobinopathies and co-infections also can decrease the number of red blood cells. Inherent disease such as thalassemia, malnutrition, and concomitant infections such as helminthosis can aggravate anemia. This table can help to compare the infection and aspect that we see in Plasmodium vivax malaria and Plasmodium falciparum malaria. If you compare type of infection, infected blood cells, in malaria vivax we have exclusive preference for reticulocytes, and for falciparum we have infected red blood cells of all ages. Parasitic load for vivax we have usually low, less than 2% of the red blood cells, and falciparum often high, over 5% of red blood cells, and can reach 30%. Destruction of infected red blood cells in vivax is very high. Estimate of 34 infected red blood cells are removed from every infected red blood cell. And falciparum is very small, about 8 uninfected red blood cells for every infection. Kidnapping in the spot for vivax, it doesn't happen. Parasite circulation freely. In falciparum, yes, parasite is hijacked in the vascular endothelium, avoiding splenic filtration. Red blood cells and deformation happen in vivax, red blood cell infected, and they are able to keep deformation. For falciparum, infected red blood cells become rigid with a greater chance of being hijacked. Change in the bone marrow dysfunction in vivax is less evident. On direct toxicity of the parasite on erythroblasts. The change in the blood marrow in falciparum is much more frequent, including erythropoiesis suppression. Hemolysis, extravascular removal predominates in vivax and less intravascular hemolysis. In falciparum, more frequent in vascular hemolysis due to massive rupture of the red blood cells. And typically of vivax, relapse just occur in vivax and not in falciparum plasmodium malaria. And of course, there are platelet alteration associated with malaria. Changes in volume and morphology. Can see increase in mean platelet volume, increase in platelet distribution with elevation large platelet cell ratio, change in platelet criticality. These platelet indicates are considered reliable markers for platelet activation and can be measured quickly and costly effectively using automated hematology analyzer. Actually, there are several factors, including to the contributing to malaria associated to thrombocytopenia, as listed here. However, reduction in platelet count is often without functional platelet impairment. So what is the clinical interpretation of thrombocytopenia in malaria? Severe thrombocytopenia, platelets less than 5,000, occurs frequently, ranging from 24 to 94% of cases. It's not a criteria of formal severity of malaria, but it is a constant finding in severe cases. There is no evidence that it causes severe malaria on its own. Episodes of severe bleeding are frequent due to bone marrow compensation. Release of megakaryocytes and megaplatelets are factors that preserve hemostasis. This study effectively highlights the diagnostic value of platelet count in malaria. It reports that a positive SD bioline malaria antigen test, a RDT test, when associated with thrombocytopenia, demonstrate 100% positive predictive value for Plasmodium vivax malaria. In malaria, neutrophils become active and show functional changes such as increased phagocytosis, reduced migration in vitro, and decrease of cytosine production, with fluctuation in total white blood cells count being less relevant for diagnosis compared to thrombocytopenia and anemia. In addition to standard complete blood counts, as demonstrated, modern hematology analyzers provide valuable complementary parameters that can offer early diagnostic clues for malaria and dengue, especially in settings where confirmatory tests are not readily available. In these studies, samples from patients with malaria, dengue, and other febrile illness were analyzed. Automatic hematologic analyzers generally generalized a series of diagnostic flags and derived parameters that proved to be highly sensitive and specific for these infections. Statistical models based on these parameters achieved a sensitivity of 90% and a specificity of 88% for malaria, with an area under the curve of 0.93, a performance level similar to many specialized diagnostic tests. The authors conclude these results are promising in ongoing quest to develop accurate, reliable, and rapid hematologic analysis-based diagnostic tests for these serious tropical illness. I fully agree. In this study, two figures on the left illustrate how automatic hematology analyzers can identify distinct patterns in the blood profiles of patients with tropical disease, particularly malaria and dengue. In the figure 1, on the top, white blood cells, it's a white blood cell histogram. In a healthy control, the figure A, we see well-defined peaks with lymphocytes, monocytes, and neutrophils appearing in the clearly separated regions as expected. In the patient with malaria B, a characteristic early peak appears at the start of the graph. This peak reflects the presence of non-lyse paralyzed red blood cells entering the white cell chamber, an alteration that is highly specific and is strongly suggestive of malarial infection. Additionally, there are notable shifts in T1 and T2 peaks, producing a clearly abnormal pattern. In dengue, let us see, the histogram shows a rightward shift of peak T1 and T2, along with the broadening of the lymphocyte peak, indicating a typical immune response. In contrast, in typhoid fever, letter D, as well as in other infections such as leptospirosis and rickettsiosis, the histogram remain nearly identical to health controls with no significant alterations. In figure 2 on the bottom, differential shows differential white cells scatter plots. In healthy individuals, letter A, cells population are well separated. Lymphocyte, monocyte, neutrophils, and eosinophils appears organized into distinct clusters. In malaria B, this organization is completely disrupted. Lymphocytes and monocytes migrate into the regions normally associated with immature cells, such blasts, reflecting a significant disturbance in hematologic differentiation. A similar pattern is seen in dengue, letter C, with lymphocytes and monocytes expanding into the blast in variant regions, along with the clear leukopenia. In typhoid fever, letter D, the scared plots remain similar to those with health controls, reinforcing the specificity of the hematological changes observed in malaria and dengue. Now, turning to the figures on the right, we see nuclear red blood cells, NRBCs, scattered plots. which help differentiate white blood cells from other elements in the blood, such as parasite red cells, platelets, and their variants. In the panel A and B, health and control cells population are clearly separated. Leukocytes in blue, platelets in green, few or non-red blood cells, which would indicate NRBCs or normal cells. The distribution is clear and well organized. And panel C and D, when we see malaria, we observe a dense green cluster marked by a white and red arrow. These clusters corresponds to a paralyzed red blood cells that were not leased and highly specific finding in malaria on automated analyzers. Panel E and F, we have dengue, typhoid fever, leptospirosis, and rickettsiosis. In these cases, this scattered plot appears similar to those with health individuals without distinct cluster seen in malaria. This automated graphical pattern reinforces the value of modern hematology analyzer as rapid an auxiliary tool for the screening of severe tropical disease, particularly in resource-limited settings where confirmatory diagnostic may be delayed or unavailable. Returning to the context of Brazil, approximately 99% of malaria cases in the country occurs in the Amazon region, shown in the green on the map. Next. However, despite of the highly burden of the disease, the malaria case fatality rate in Amazon is relatively low, recording at 0.04% in 2023. In contrast, next one, in non-Amazon or extra-Amazon regions, the case fatality rate can be up to 51 times higher, reaching 1.85%. Next one. This stark difference is largely due to delayed or missed diagnosis. Without clinical suspicion and proper laboratory investigation, malaria is not diagnosed, which leads to increase in morbidity and mortality. Next one. Given the existing laboratory capacity, it is essential that samples displaying hematological pattern suggestion of malaria or dengue be systematically flagged to trigger further diagnostic testing. Next one. I'd like to close by once again thanking Siemens for the kind invitation to be here with you today. This opportunity emerged from the conversation we began early this year when we started evaluating the Atelica EMA 530 in the state of Rondônia. I was particularly excited about the potential use of the complete blood count analyzer as a screening tool for malaria and dengue, and approach that is highly relevant to the reality we face on the ground here. The dynamic nature of this disease, together with changes in the relationship between the environment, people, and the parasites, demands a continuous flow of innovative strategies to overcome the technical and logistical complexities. Therefore, well-established tools, when combined with innovative technologies such as algorithms and artificial intelligence, have a potential to significantly strengthen our response to both current and future threats posed by tropical disease. Thank you very much.